all disorders one by one. Depression. I'm sure this photo can describe everything about depression. You cry alone and no one is going to hear. No one is going to listen, right? Basically, this is all about depression. Anyone can get depression. Let's understand this part. See here, first of all, let's talk about neurotransmitters. Remember, decreased level of serotonin, norepinephrine and dopamine. Decrease the level of BDNF also. BDNF, brain-derived neurotropic factor. Yes, decreased level of these neurotransmitters can cause depression, especially if I have to choose two, especially serotonin and norepinephrine, especially. Now, see here, if I ask you, suppose if you are getting a depression case in your OPD, are you going to start your patient on antidepressant without ruling out other disorders? No. Depression can be seen in other disorders also. First of all, rule out other diseases. After that only you can start your patient on antidepressants. Because see, remember here, suppose if there is a patient of hypothyroidism, please mention here. In hypothyroidism, yes, depression can be seen. Okay, and whenever there will be dysfunction of HPA axis, what is this HPA axis? Hypothalamus, pituitary and adrenal gland axis. Remember here, see here, so whenever there will be dysfunction of HPA axis, yes, there can be what? Increased level of steroid secretion. Okay, increased level of steroid secretion. So what is happening here? So this can be seen even Cushing syndrome also, and depression also. Remember here, approximately 50% patient of depression will be having what? Excess level of this secretion, excess level of cortisol secretion. Rule out everything. After that, yes, even in some vitamin deficiencies also there can be depression, like deficiency of vitamin B12, deficiency of vitamin B9, folate, folic acid, and deficiency of vitamin D. Long-term medical illnesses, yes, long-term medical illnesses, like suppose if a patient is suffering from cancer or some other long-term, like long-term illnesses like long-term diabetes, long-term hypertension, when a patient can go into depression. Yes, these are the risk factors. Which drugs can cause depression? Very, very important, related to your psychopharma. Remember here, most important drugs which we should be focusing on here. Yes, use of beta blocker, use of OCPs, even steroids. Remember here, when I talk about steroids, see, steroids can cause mania also. Steroid can cause depression also. Even use of barbiturates. Use of all these medications can cause what? Depression. Even use of interferon also, right? Interferon also. I hope all these points are clear to all of you, right? And yes, as per the neuroanatomical, it is seen that decreased activity in dorsolateral prefrontal cortex and increased activity in amygdala. So remember all these points. See here, so far I have been explaining what? Basics of depression. Now, see here, some features we should be focusing on. Overall lifetime prevalence is 5 to 17%. Remember, depression is more common among females, middle-aged females, right? Okay, higher risk obviously. See, remember, whenever there is loneliness is very, very high risk factor for causing depression. So yes, like among divorcee people, among separated people, when a person is alone, when a person is having so much solitary lifestyle, a person can go into depression. And remember here one point, that Depression is responsible for maximum daily. What is the meaning of maximum daily? Daily means what? Disability adjusted life years. What does it mean? What is the meaning of daily? What I'm saying here that depression is a psychiatric condition, and a psychiatric condition which can cause maximum daily. This is what? Depression. What is the meaning of daily? Disability adjusted life years. I am adjusting in my normal life because of my disability. Suppose if a person has got femur fracture, right? Femur fracture. Shaft of femur fracture. After that, he got operated. Now he is bedridden for 1 month. He is bedridden for 1 month. Do you think he has adjusted 1 month because of his disability? Yes. This is called as daily. So a person is wasting so many healthy days because of depression. So please remember that depression can cause maximum daily, most burdensome disorder, because this is having so much recurrence also, and like approximately 15% depression cases are resistant to treatment. Approximately 15% I am saying. So there is very high resistance. See here, there is what? High recurrence. This is most burdensome, and this is one of the most common causes for suicide also. See, suicide rate in depression is 10 to 15%. Now see this question. Which of the following is not a risk factor for attempting suicide? After reading all these 4 options, I'm sure you would have got a smile, right? And I don't remember if this question was asked in any PG exams. Just for the fun, I have added here. So obviously answer is what? Married man. Out of these 4 options, see, why do you think married man is always at the risk of suicide? But mentioning this question is an important thing here. Why? Because remember here, depression is one of the most important causes for suicide. And suicide, especially when we talk about India, in India, this is extremely prevalent. We have to understand about depression. We have to understand about suicide. What are the risk factors for depression? Those risk factors can be the cause for suicide, right? Do you understand here? Okay, so what are the risk factors for depression? We can learn with the help of biopsychosocial model, and this is frequently used to describe so many mental conditions. So what are the biological factors which can cause depression? Yes, family history. Yes, and there can be the genetic predisposition, especially related to serotonin. Yes, there can be genetic predisposition, genetic. Okay, some other biological factors: decreased level of serotonin, norepinephrine, dopamine. Very easy to understand. What are these psychological factors which can cause depression? See here, Aaron Beck, he gave a cognitive triad of depression, that if a person is having hopelessness, helplessness, worthlessness type of feeling, he is at the higher risk of depression. What I am saying is that hopelessness, no hope; helplessness, no one can help me; worthlessness, I'm the burden on the earth. Yes, psychological, right? Now psychological, maybe after death of some loved ones. Okay, social condition like loss of job, loss in a relation, so much social pressure, family pressure. Yes. So see here, all these can be the risk factors for development of depression. Remember here, apart from these also we can understand that, see here, whenever there will be loss in family, loss in business, loss in exam, long-term illnesses, yes, these are the risk factors for depression also, suicide also. Okay, now understand this part here, that you must have heard that some people in depression, they are eating a lot and some do not eat at all. Some people are sleeping a lot, some do not sleep at all. How there is the difference here? Remember here, different types of depression we are going to learn. Typical depression, atypical depression. But when I ask you, typically, what will be the features of depression? What do you think? A person will be sleeping a lot, or he will be sleeping very, very less? Less. He will be eating a lot, he will be eating very, very less? Very, very less. So, what are the typical symptoms? What are the symptoms? What are the features of typical depression? First of all, lack of mood. I can say sadness, right? Sadness. Yes, there can be anhedonia. What is the meaning of anhedonia? Inability to experience the pleasure in old activities. Patient will say, earlier I used to enjoy, now I do not enjoy. Anhedonia. Yes, there can be lack of sleep, insomnia, lack of food, anorexia. Anorexia. A person will not be having good food habit, right? So now you tell me, when a person is not sleeping, when he is not having proper diet, when he is not having good food, do you think there will be hyperactivity or less activity, less energy? Remember here, decrease in psychomotor action. So basically I can say what? Decrease in physical activities, right? See, decrease in motor function, right? Now, after seeing all these conditions, now you can easily understand that there will be what? Lack of energy, lack of attention, lack of concentration, lack of judgment power. Very easy to understand. Now you tell me, when I talk about typical depression, do you think people will be having good feeling or feeling of guilt? Obviously, feeling of guilt, no? Feeling of guilt is very commonly seen, no? Feeling of guilt. Feeling of guilt. I could not make good friends. I could not make so much money. I had been a failure person, right? Feeling of guilt, right? Feeling of guilt. So there will be well-composed thoughts, well-organized thoughts or negative thoughts. Yes, patient can have negative thoughts. Negative thoughts. Patient can have what? Negative thoughts. Yes, there can be suicidal thoughts. There can be suicidal thoughts. Now you tell me, when a person is not having good food, when he is not having good sleep, now you tell me what will be happening to weight? Obviously, there will be weight loss, decreasing weight. Remember, see, especially you have to focus on these four. Remember, sadness, okay, loss of weight, anhedonia, suicide, and a feeling of guilt. Out of these symptoms which I have mentioned here, remember, equal to or more than 5 symptoms, equal to or more than 5 symptoms for more than 2 weeks, for more than 2 weeks, for more than 2 weeks or for more than 14 days, you can say what? He or she is 100% suffering from depression. These are typical depression symptoms, typical depression features. I hope all these points are clear to all of you. Now, there is a type of depression. What is happening there? Reversal of biological symptoms. What I am saying here, that reversal of biological symptoms. Reversal of biological symptoms. See here, a person is going to sleep a lot. Now there can be what? Increase in sleep. Hypersomnia, he will eat a lot. Hyperphagia, there will be increase in weight. Increase in weight, there will be obesity. And when something good will happen, like suppose if there is any birthday party, suppose if there is any function, suppose if there is any marriage ceremony, these kind of people, they will be happy, right? So there will be reactivity of mood. This is called as mood reactivity. This is called as mood reactivity. Mood reactivity means if something good will happen in between, he or she will feel happiness there, right? Sometimes there can be feeling of discrimination. Patient will object, patient will be having emotional outbursts, patient will start complaining to the family members that you people are not loving me anymore, you people are not caring about me, right? Now, this is called as interpersonal sensitivity. Interpersonal sensitivity. Even for this simple thing, patient can get irritated, agitated, he will start complaining a lot. This is what? Interpersonal sensitivity. And sometimes because of decrease of psychomotor activities. Now, when a person is always lying down, see, a patient can complain that, sir, I'm not able to lift my limbs. Okay, so these are very, very heavy. I cannot lift it, right? This is called as what? Heaviness of limbs. This is called as laden paralysis. Laden paralysis. So, these are the symptoms which we are going to see in atypical depression. Remember here, see here, when we are going to learn about the management of depression, obviously we will be learning about TCA, SSRI, MAO inhibitor. So many drugs are there, right? So remember, in atypical depression, TCA doesn't work. Here, best medicine which is going to help the patient a lot, that is MAO inhibitor, monoamine oxidase inhibitor, and next line is SSRI. But remember, no TCA is going to help here. And see, especially when I talk about the typical depression in some patients, especially among old patients, especially among old age, we can see melancholic features. Melancholic means what? Solitary person. Melancholic, this is an English word. What does it mean? Sad, silent and alone. In which age group this will be very, very much common? During old age, right? So, old age depression, melancholic especially, which is also called as involutional melancholia. See here, there will be severe feeling of guilt. Severe feeling of guilt. See, you can say old person can have miserable feeling. Miserable feeling. Early morning awakening is classically seen. Early morning awakening. Early morning awakening. What does it mean? Patient will say that, sir, earlier I used to get up by 7 a.m. But now without alarm I am getting up by 5. This is early morning awakening. Classically seen here. Remember here, when depression is there, sleep problem will be there for sure. Okay, fine. Now see here, there is very high risk of suicide. I hope all these points are clear to all of you. Now you can easily differentiate typical depression and atypical depression. Typical depression means what? Yes, there will be sadness, insomnia, lack of food, anorexia, there will be weight loss, suicidal thoughts, negative thoughts, right? Lack of energy, lack of attention, lack of concentration. And atypical, reversal of biological symptoms like hypersomnia, hyperphagia, obesity, right? And some other symptoms of atypical depression, please remember here that, like interpersonal sensitivity, mood reactivity, and one more is what? Laden paralysis. Please remember all these points. Depression is very, very important topic for patients also and for exam also. Okay, so what are the physical signs of depression? See here, whenever you are going to see a depressed patient in your OPD, first of all, look at the forehead. See, like most of the depressed patient will be like this only every time, sad, 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 and they will be having, like forehead. So what is happening here? See, because of this habit, sometimes, yes, there can be the contraction of muscles over forehead, especially near the glabella, above root of nose and upper part of eyelid. Because of the contraction of procerus muscle, what is happening here? See, there can be a sign like this. Look here. Okay, this one, this is called as what? Omega sign. Omega sign. And because of orbicularis oculi, upper part of the eyelid, this part here. Right now, this is called as Veraguth fold. Remember here, these can be your image-based questions also. Remember, above the root of nose, there can be omega sign, and a triangular fold near nasal corner, This is Veraguth fold, Very easy to understand. All right. And we can see psychotic symptoms in depression also. But do you think in all cases of depression we can see psychotic symptoms? Mild, moderate, severe, or? No, remember here, psychotic symptoms like delusion, hallucination, this can be seen in, especially in severe depression and sometimes in moderate depression. So what is the meaning of mild, moderate and severe depression? See, when I am saying mild depression, moderate depression and severe depression. Mild depression means what? Only symptoms are there. Only symptoms. Moderate depression means what? Symptoms of depression with there will be a problem in sleep and diet. Sleep and food habit. Sleep and food habit. What is the meaning of severe depression? Along with the symptoms, yes, there will be the problem in food habit, sleep habit. Along with that, there will be a problem in functions also. There will be many dysfunctionalities also. Very easy to understand. Fine. So now we can understand, okay, severe depression, where there will be symptoms of depression, where there will be problem in sleep and food habits, and when there will be so many of dysfunctionalities also, right? So remember, in severe and moderate depression, we can see psychotic symptoms. Let's understand this part here. Now, what kind of delusion can we see here? Especially if I mention here, suppose if a person is having depression with a delusion of negation, nihilistic delusion, where a person is claiming of non-existence of something. Suppose if a patient is saying that aliens have stolen my brain, right now. So yes, this can be seen with depression. If this delusion with depression is occurring, this is called as what? Mood congruent. But if a person is having depression with a delusion of grandiosity, see, if he's saying that I am the richest man, it doesn't suit him, right? This is called as mood incongruent. This is called as what? Mood incongruent. Remember, in depression, we can see catatonic symptoms also. What is the meaning of catatonic symptoms? Motor symptoms also, which we have learned so many, so many catatonic symptoms in schizophrenia, right? Approximately 15, 16 catatonic symptoms we have learned in schizophrenia, right? So remember, which catatonic symptoms can be seen among depressed patient? Stupor and negativism. What is the meaning of stupor? Stupor means immobile, hypomobility. All these points are clear to all of you, right? Now, see here, Aaron Beck, this point I already have explained. But one more time, we can have understanding about this psychological theory of depression. Aaron Beck, who explained CBT, cognitive behavior therapy, right? He also gave cognitive triad of depression. He said that if a person is having negative feeling about future, negative view about future, negative view about environment, and negative view about himself. Basically, when a person is having feeling of hopelessness, helplessness, worthlessness, after failing in this exam, if a person is saying that I can never be able to pass any exam, no one can help me, I'm just a burden on the earth, right? If a person is saying all these statements, no, for sure, you can easily understand that he is suffering from depression. And now we are going to learn treatment modalities of depression. Earlier, TCA was the first line of drug. Earlier, so many TCA drugs are there like amoxapine, imipramine, so many drugs are there, right? Earlier, TCA was the best, but remember here, TCA had so many side effects. TCA was blocking serotonin, norepinephrine. In this manner, this was increasing the level of serotonin and norepinephrine. Okay, fine. Suppose only this much was there. No, my patient would have been the happiest. But TCA was also antagonizing muscarinic receptor, histaminic receptor, alpha 1, alpha 2 receptor, sodium gated channel of heart, and this was also causing metabolic acidosis. So overall, because of this secondary effect over muscarinic receptor, histaminic, alpha 1, alpha 2, sodium gated channel of heart, and metabolic acidosis, patient was suffering a lot. Patient had so many side effects. First of all, we are going to learn about TCA toxicity, what can be the side effects and all, right? Because this is an important topic for the exam. Management of TCA toxicity, what are the investigations to be done in a case of TCA toxicity, and how to treat. Okay, see that TCA is blocking serotonin and norepinephrine. With the help of this is going to increase the level of serotonin and norepinephrine. This is good for the patient. But what about antagonistic effect on muscarinic receptor? Now there will be some side effects. My patient is saying that, doctor, the medicine which you have given me, after that I am having problem in my vision, I am having constipation also, dry mouth also, problem in urination also, right? So what are the anticholinergic side effects here? Blurred vision, dry mouth. There can be constipation also, and patient is having urinary retention also. When I am saying blurred vision, suppose if you have a patient of glaucoma with depression, can you start your patient on TCA? No. Remember here, not in a case of glaucoma. Now suppose if you have a patient of BPH, benign prostatic hyperplasia, with depression, can you start your patient on TCA? No. Because in BPH, there will be very, very high level of what? Urinary retention. This will be there, no? Right. After that patient is complaining what? Doctor, after starting on your medication, now every time I'm having what? Lightheadedness. What is happening? Because of the alpha blockade, there is what? Hypotension. Now, what are the cardiac side effects? My patient is complaining that after using this medication, I am having palpitations, tachycardia, I am having arrhythmia also, right now? Fine. So what is happening here? Patient can have palpitations. You can write what? Arrhythmia. Okay. What are the neurological side effects? Neurological side effects can also be seen there. Yes, there can be tremors. There can be seizure also. Because of alpha blockade, what is happening here? My patient keeps on complaining that after using your medicine, every time I keep on sleeping. Excessive sedation, right? Excessive sedation. And because of tissue hypoxia, remember here, patient can have metabolic acidosis also. Which is very, very dangerous. Now, easily you can understand here that if patient will be having TCA toxicity, after seeing these signs and symptoms, you can easily understand, like in a patient who was already on antidepressant, right? If I ask you, what are the investigations to be done after TCA toxicity? Obviously, ECG should be done. ABG, arterial blood gas analysis, should be done, right? Since there is metabolic acidosis, how will you treat? Acidosis is very dangerous, no? When acidosis is there, there can be damage of multiple organ, right? No? So remember here, as soon as you are able to understand that patient is into metabolic acidosis, we have to do what? Serum alkalinization. We have to give injection of sodium bicarbonate, IV. Okay. See here, so what are the investigations we have to do here? ABG, especially we have to check what? Metabolic acidosis. ECG, what exactly you are going to see on ECG? Remember here, you are going to see increased level of PR interval, QRS and QT interval. You are going to see AV block, right axis deviation. So remember here, so whenever there will be QRS interval of more than 100 millisecond, no, right? At that time, for sure, you have to do what? Serum alkalinization. How? You have to give IV sodium bicarbonate. Okay, fine. Suppose if there will be overdose, obviously gastric lavage should be performed. I hope you can understand the management of TCA toxicity. After seeing the secondary side effects of TCA, now I'm sure easily you could have understood that TCA should not be the first line of management for depression. Now, first line of management is SSRI, selective serotonin reuptake inhibitor. So many SSRIs are there like escitalopram, sertraline, fluoxetine, okay, paroxetine and the dapaxetine. Yes, SSRI also has some side effects but not like TCA. We are going to learn everything about SSRI also. Yes, we can also use SNRI. See, for SNRI especially, we have to mention some points that SNRI especially, when do we use? When a person is having lack of motivation, when a person is having lack of energy, when a person is having lack of energy. Remember especially which SNRI we are using? Venlafaxine, desvenlafaxine. Venlafaxine, desvenlafaxine. So actually so many SNRI are there, but especially we have to focus on venlafaxine, desvenlafaxine. But remember here, side effect of these two on long-term exposure can be hypertension, because SNRI, selective serotonin norepinephrine reuptake inhibitor, right? So because of the increased adrenergic tone right now. So remember here, on a long-term use of SNRI, especially venlafaxine and desvenlafaxine, side effect can be hypertension. All right. And now say this question, which of the following antidepressants is least likely to be associated with sedation? With the help of this question, we are going to understand which antidepressants can cause sedation and which will not be causing sedation. Remember here, most of the antidepressants can cause sedation. When I talk about TCA, mirtazapine, Razadone, yes, these are the drugs which can cause sedation. But especially when I talk about SSRI, SNRI, remember they can cause what? Decrease in sleep. Decrease in sleep. Side effect of SSRI, you will be learning that vivid dreams or increased dreams. Remember, increased dreams. So here only we can understand that suppose if I have a patient with depression and insomnia together, then which antidepressant we should be choosing? Which antidepressant? Remember here especially TCA, mirtazapine and Razadone. And if I have a patient who is having depression with hypersomnia, who is sleeping a lot, in this situation, I can use what? SSRI or SNRI. When I talk about this medicine, see this antidepressant, very, very important. Recently, in one of the PG exams, they have asked, which antidepressant can cause priapism? Which antidepressant can cause priapism? Please mention here. Razadone can cause priapism. What is the meaning of priapism? Priapism means what? Painful erection of penis. Painful erection. And this topic you will be learning in urosurgery. Priapism. Painful erection. For this, for the priapism, you have to perform a surgery, shunting surgery, right? So remember, which antidepressant can cause priapism? Answer is what? Razadone. Important. Okay. Recently, this was the question, so we should mention here and please keep in mind. See this question. A 40-year-old female using antidepressant for last 5 months. She is complaining of weight gain. She is asking to change the medicine. Now, which medicine will be more preferred in her case? Remember, with the help of this question, we are going to understand which antidepressants can cause weight gain. Remember, when I talk about TCA, when I talk about SSRI, SNRI and mirtazapine, remember here, all these drugs will be causing weight gain. All these drugs will be causing weight gain. Okay, so here we have to talk about Bupropion. Remember here, Bupropion is an antidepressant. This is what NDRI, noradrenergic dopamine reuptake inhibitor, and one SSRI, fluoxetine. Okay, they have least side effect as the weight gain. So safe drug will be what? Bupropion and fluoxetine. Remember here, with the help of this question only, we have learned some drugs which can cause weight gain. These drugs are what? TCA, SSRI, SNRI and mirtazapine. Fine, no? So safe drugs which will not be causing weight gain, that will be what? Bupropion and especially fluoxetine. I hope you have learned something more about Bupropion. Remember here, Bupropion can be used in some other conditions also. Remember, Bupropion can be used in ADHD also. Okay, atypical depression, yes, and this is also an anti-smoking drug. Anti-smoking drug. All these points are important. Okay, fine. Now we are going to talk about side effects of SSRI. SSRI do not have that much serious side effects like TCA, but yes, SSRI also has some side effects like short-lasting GI side effects, like there can be nausea and vomiting. See, there is a rare side effect of SSRI. Sometimes there can be GI bleed. Sometimes this is actually rare, but very important for your exam. Okay, SSRI can cause GI bleed. So whenever you are suspecting, no, there can be GI bleed, right? Then along with SSRI, please add PPI, proton pump inhibitor, like pantoprazole 40 milligram. That should be given in empty stomach, right? Remember, on long-term use of SSRI, there can be sexual dysfunction. Which type of sexual dysfunction? Please mention here. Delayed ejaculation. Delayed ejaculation. That's why SSRI is used in the treatment of premature ejaculation, because side effect of SSRI is what? Delayed ejaculation. Sometimes, remember here, sometimes because of SSRI, yes, there can be some CNS side effects also, like, you know, like there can be anxiety, there can be insomnia, sweating. And remember, especially related to your exam, because of SSRI, there can be vivid dreams, nightmares and all. This is important for your exam. Sometimes, yes, there can be anticholinergic side effects also. Blood related, sometimes there can be some problem in aggregation of platelets. Okay, weight gain. All these points we have to remember, we have to memorize, we have to take care of all these side effects, right? But remember here, SSRI, these days, this is the preferred drug for the treatment of depression. Treatment of depression. Remember, SSRI overall, this is like metronidazole of, you know, like psychiatric medications. Why? Because SSRI can be used at so many places in psychiatry, you know. See, SSRI can be used for the treatment of depression, for the PMS symptoms, right? For eating disorder, sexual disorder, anxiety disorder, phobia, PTSD. In all these conditions, yes, SSRI can be used, right? Okay, see this question now. A patient is on treatment of depression complaining of painful coitus, or you can say sexual dysfunction. Which drug will you switch him on to address his problem? Basically, when you have started a patient on antidepressant, patient is complaining of sexual side effect. Now, what should be the next line of management, right? If there will be sexual side effect, for sure, patient will complain, right? See all these options. When I talk about imipramine, venlafaxine, escitalopram, Imipramine is what? TCA. Venlafaxine is what? SNRI. And escitalopram, SSRI. Remember one physiology. Whenever there will be increased level of serotonin, whenever there will be increased level of serotonin, 5-HT, okay, serotonin, this can alter hormone also, neurotransmitter also. Serotonin can alter, it can affect dopamine, and this can affect testosterone also. This can affect testosterone also. I hope all of you remember this point, that dopamine is responsible for kick. Because of dopamine, there will be orgasm. Right now, there will be orgasm. So, whenever there will be excess level of serotonin, now dopamine level will be altered. Remember here, now there will be problem in achieving orgasm. Now there will be problem in achieving orgasm. Okay. Because of the testosterone, what will be the side effect? Now there can be decreased libido, lack of libido. Now there can be erectile dysfunction also. So what I am saying here, that in any medicine where level of serotonin will be increasing, yes, there can be sexual side effect. So see, in a case of imipramine, here also level of serotonin, norepinephrine will be increasing. So this is also wrong. Okay. Venlafaxine, SNRI, yes. Escitalopram, yes. So C and D we cannot use. What about bupropion? What about bupropion? See, mechanism of action, this is what? NDRI. Noradrenergic dopamine reuptake inhibitor. There is no serotonin. So remember here, safest drug which will be having least side effect as a sexual side effect is what? Bupropion here. So answer is bupropion. Please mention all these points. Okay, so which antidepressants are safe? Which antidepressants have very minimal or no sexual side effect? Especially you have to mention here bupropion, okay, mirtazapine, trazodone, and vortioxetine. Please mention that these are the drugs which are having very less or minimal sexual side effect. Okay, suppose if there is a patient of depression in your OPD, okay, he is already a known case of bipolar disorder. So basically bipolar depression. He is already on lithium. You did not take the history. You have started your patient on SSRI. So basically along with the lithium, SSRI is given. Lethal combination. Remember here, along with SSRI, there should be no administration of MAO inhibitor or lithium or L-tryptophan. Remember here, because this can raise the plasma concentration of serum a lot. And what is happening here? See, remember, this can be very, very dangerous for the patient. This can be a fatal condition. Remember, this is called as serotonin syndrome, where what kind of symptoms can the patient have? Remember here, there can be GIT symptoms, severe restlessness, hyperreflexia. There can be seizure, myoclonus, rigidity and all. And finally, patient can go into delirium, coma, and finally, death. This is called as serotonin syndrome. So only supportive care, and you can give what? Cyproheptadine. Okay. So remember here, serotonin syndrome is a fatal condition. Now, suppose if we have started a patient on any antidepressant drug. Okay. Suppose if we have started your patient on any drug and you have started with 10 milligram. Okay. You have asked your patient that you have to take for 6 months. After 2 months, patient came, but no improvement in symptoms. No improvement in the symptoms. You ask the patient, did you take complete dose? Patient is saying, sir, actually I read on Google that, like so many side effects. So I reduced the dose. I was taking only 5. And some patients can abruptly stop in between. Sudden stoppage of any psychiatric medication. Remember here, this can cause discontinuation syndrome. Now patient can have some symptoms of discontinuation syndrome, like see, there can be rhinorrhea, see, there can be headache, there can be running nose like flu-like symptoms, there can be sleep problem, there can be agitation, anger issues, nausea, vomiting. Remember, sometimes there can be what? Vertigo-like feeling, right? There can be paresthesia, anxiety, irritation and all. This is called as what? Discontinuation syndrome. Remember here, for the discontinuation syndrome, most common drug which is associated is venlafaxine, which is SNRI. Even like paroxetine and the fluvoxamine. Remember here, safest drug which will not be causing discontinuation syndrome is what? Fluoxetine followed by Bupropion. How to help the patient? First of all, psychoeducation. Educate the patient that I am the doctor, Google is not. Okay? Easy to understand. I know. Don't be so rude. Like you have to speak in a humble manner, right? Okay, fine. Be gentle with the patient. All right. So basically what is here? See here, psychoeducation to the patient is important. You have to make him understand the doses, the effects of the drugs. Like most of the drugs will start acting, after 1 week, after 2 weeks, after 3 weeks. So in this manner, you have to educate the patient. Okay. And now there is a new drug for resistant depression. When a patient was already on antidepressants for more than 2 years, he will be called as a case of resistant depression who was not responding to other antidepressant. Now there is a new drug, esketamine. I'm sure you know this fact that esketamine, this is the enantiomer of ketamine, and ketamine is also called as what? Dissociative anesthesia. This is also a drug of abuse also. So this drug can be abused. Remember? So this is given as nasal spray along with antidepressant, oral antidepressant. Remember, this can be abused, so it should always be given in front of a medical practitioner. Esketamine. Okay, fine. Now, in this manner, we have completed all medications, all antidepressants. Now, we are going to learn some other modalities of treatment for depression. ECT, electroconvulsive therapy. Remember here, ECT can be given in depression also. But do you think in all cases of depression? No. When a patient is having severe depression along with suicidal tendency, severe depression with stupor. Stupor means what? Immobile, where a person is not moving. Hypomobility. Depression with psychotic symptoms. Refractoriness to other modalities of treatment. When patient is not responding to other modalities of treatment, yes, ECT can be given. So there are 4 indications of ECT in depression. Please remember all these points. In ECT, we are giving what? Electroconvulsive therapy. These days, we have to give anesthesia also, right? Anesthesia like methotrexate, right? Remember. So for ECT, anesthesia should be given and electric shock will be given. Because of this, some side effects like amnesia, headache, right? So now we are having one more method of treatment which is called as TMS, transcranial magnetic stimulation, where we don't need to give anesthesia. No electric shock. We are using magnetic energy to stimulate the nerve cells. This is called as what? Transcranial magnetic stimulation. Here also side effect is headache. Side effect of TMS is headache. Now, vagal nerve stimulation. How a stimulation of vagus nerve can help in the treatment of depression? See, especially we are using what? Left vagus nerve. See here. Under the skin, we implant one electronic device. How it is going to help? How vagus nerve stimulation is going to help in the treatment of depression? Remember here, stimulation of vagus nerve is going to stimulate the areas of brain which can lead to seizure and affect mood. So remember, this is also important for your exam. Stimulation of which nerve can be supportive in the treatment of depression? It is vagus nerve. and phototherapy. Remember, this is especially for depression in winter, seasonal affective disorder, because of lack of light, lack of sun exposure. How to help the patient? Expose him to light right now. So how much? Remember here, 1500 to 10,000 lux for 1 to 2 hours before down each day, at least for a week. So remember here, all these are like ECT, TMS, after that phototherapy and vagal nerve stimulation. These are the methods of treatment for depression apart from medications. In this manner, we have completed depression.